Assalamu alaikum. First of all, I'd just like to thank the organisers for inviting me to speak, particularly Professor Javed, Dr. Somia, and Dr. Amjad as well. Just as a way of introduction, we've been working very closely with Pakistani colleagues for a number of years, and we have sepsis studies going on in Karachi, Lahore, Peshawar, Swabi, and also Islamabad, and indeed actually in Multan. And just before I go any further, my final notice is that I have no conflict of interest. I'm really quite pleased actually Roman spoke about sepsis, because a lot of what I'm going to speak about is sepsis. My questions that I've proposed really is managing antimicrobial resistance. Is it solvable or is it impossible? And I'll come back to that question at the end of my talk. It's just to be aware that actually antimicrobial resistance in about 20 years' time will eclipse in total cancer, TB, HIV, and indeed road traffic accidents. It will be the biggest killer on the planet. So what is antimicrobial resistance? Antimicrobial resistance is quite difficult to get your head around. I don't really understand it, and I've been studying it for 30 years. So if I don't understand it, then, you know, I guess there's not much chance of somebody I'm standing in a queue when I go and buy my shopping to understand it as well. It's quite complex, but it's essentially, fundamentally, it's the bacteria, and I will pick on the bacteria here, not other infectious organisms, that it's the bacteria that becomes resistant to the antibiotic. And so there's a difference between antibacterial and antimicrobial. Why is it tricky? It's tricky because as you sit there in front of me, you have more bacterial cells than you do human cells. Every time we defecate about 10 to the 11 to 10 to the 12 bacterial cells per gram of feces. Everywhere we go around the world, we take our bacteria with us. So we have friendly bacteria, but as Roman has said, you know, some can cause sepsis and it'd be life-threatening. So we have to sort of differentiate between friendly bacteria and those that will kill us, i.e. critical sepsis. The problem is that when you give somebody an antibiotic, you are exposing all the normal flora to that antibiotic. There is no discrimination. Why is it even more tricky? It's even more tricky because bacteria are very small. They weigh basically 5 picograms. How much is that? Not much. Just remember that answer. Not much. So that when you open a door or whatever it may be, the bacteria go everywhere. So can you imagine in South Asia, where you have cyclones and tornadoes and so on, the bacteria go everywhere. They're also carried very easily by water, etc. And so wind patterns also become very important. Why is it even more tricky? Because bacteria multiply between every 20 minutes and 1 hour. Human beings multiply every 30 to 40 years. But bacteria, every time they multiply, they have the ability to become mutants, and therefore these mutants can become resistant to these antibiotics. So I put this slide up, and this slide is essentially showing COVID, which hopefully is still in our memory, to AMR. So far, at the moment, depending, this is worldometer data, the number of deaths associated with COVID total about 7 million. Those for AMR is 5 million now, and will be sort of probably rise at least to 10 million by 2050, probably somewhere between 16 and 21 million by 2050. It's going to dwarf COVID. Right now, in many countries, we have COVID year in, year out. Who will be affected? COVID affected those that had asthma, obesity, and also the very elderly. With AMR, it will be neonates, pediatrics, particularly with life-threatening infections like sepsis, and also females. Females are always at risk. There is a disproportional risk factor with females acquiring antimicrobial resistance for a whole variety of reasons. How much will it cost the global economy? So far, COVID has cost us between 12 and 14 trillion, depending on whose figures you believe. AMR will cost us over 100 trillion. It is essentially something like about a fifth of the worth of Europe. That just shows you we will not survive this economically. Which countries are going to be most affected? With COVID, interestingly enough, it was high-income countries mainly, and middle-income countries. So when I go across Africa, they go, well, you know, COVID really hasn't happened here. Pakistan was the first country I came to after COVID. I came here in December 2020. And essentially, you guys were super relaxed. No face mask, you know, alcohol rubs, really? And meanwhile, in the United Kingdom, we had lockdown. You know, and so there was a really disproportional way in which countries dealt with COVID. Can it be fixed by a simple vaccine? COVID, yes. You probably might have had the AstraZeneca Oxford vaccine. That was free of charge. Moderna and Pfizer one were far more expensive. But the most important thing is with AMR, there is no vaccine at all. It's really complicated. Can diagnosis be implemented quickly with COVID? Yes, it can. All of us did a lateral flow, stayed at home, etc., etc. AMR, no, we cannot do that. It's just impossible to do. Sorry. So the other thing that we have done very recently, we published this paper in Lancet Microbe, is that we try to understand actually how widespread AMR can be. And the problem that we sort of had up until now is that we've relied on microbiology sort of methods to try and assess this. But in fact, what we started to do was develop methods that were non-culturable. In other words, we didn't have to go into the lab. And when we started to look at this, we found that actually genes or plasmids can cross the gram-negative, gram-positive barrier. That just blew our mind because we actually broke the paradigm of the transmission of AMR. And secondly is that the frequency of transfer was far greater than what we first thought. And that's one of my students who actually undertook this work. We've also, and this is, I'm not going to show you any data, but we've done this analysis, and then we've basically looked at pollution, in this case the effects of plastics, microplastics, on the bacteria, and whether they induce the bacteria to spread AMR more. And the answer is yes, by about 1,000-fold to about 10,000-fold. And that's crazy. And so the way in which we actually deal with our environment, not just in terms of waste and managing waste, but actually microplastics actually transmit more AMR. And the other problem is that antimicrobial resistance is associated with bacteria, and the bacteria are not just in the hospitals, but they're in waste and they're in the animal sector as well. And the way we use antibiotics in the animal sector really hasn't changed in the last 70 years. This is a study that Breshner Hassan did, and Breshner's sitting over there, and this was actually done in Peshawar in, I think, KTH. And what we found was that actually insects carry AMR bacteria at a huge rate. And when we started to kind of map this out, I'm not going to show you the data because there's not enough time, we worked out that by 2080, there could be 50,000 trillion flies carrying carbapenem-resistant bacteria. 50,000 trillion. There is only roughly 8 billion people on planet Earth. Okay, so that gives you some idea of the enormity of this, and so we're doing more studies to understand the impact of that. This is the United Nations Sustainable Development Goals. Antimicrobial resistance is at least associated directly with 14 of those, and indeed I think is associated with all of those. This is just photographs that I've taken on Gaza. And regardless of your politics and what you may think about war zones, etc., when you have a breakdown of infrastructure and you have breakdown of sanitation, you will also have spread of antimicrobial resistance. This is flooding, which is about, these photographs are 9 months old. This is where we work in China, just outside of Beijing. And you can see the massive amount of flooding. In Pakistan, just a few years ago, in this, I think it's called the Sindh region and the Balochistan region, the amount of flooding that happened in Pakistan was the size of Switzerland. And you had massive contamination of potable water with fecal material. So it's really, really important. Sadly, as I mentioned before, we've used the same antibiotics in humans to treat infections, and ampicillin, by the way, is still recommended by the WHO for the treatment of sepsis in both adults and neonates, as we do in raising poultry and indeed other meat sources. These are the figures that by 2050, the world's population will increase by roughly 2 billion. Poultry production will increase, as will indeed antimicrobial usage. I'm going to show you one slide just to illustrate this. This was a review done by Thomas van Bockel. Every single class of antibiotic that we currently use in animals has a forecast increase. And these are the regions around the world that will have been using those antimicrobials more. It's an insane thing we're doing, and it has to stop at some point. I'm now going to talk about the burden of antimicrobial resistance. I mentioned it earlier on. Roughly 5 million deaths are caused in here and now. Actually, this data was from 2019, so it's probably got worse. And as I said, the forecast is at least 10 million by 2050. These are the regions that are affected, and you can see that Sub-Saharan Africa are one of the worst regions, but you can see that South Asia, including Pakistan, are also one of the worst regions to be affected. And AMR in Pakistan is extremely high. Just going to talk very quickly a few minutes about Barnard's, which is a neonatal sepsis program that we have across these particular countries. These are the areas and the sites, and we also have a program not just on neonatal sepsis, but adult sepsis, comparing high-income countries to low-income countries. This is a study, and it's really important to just spend a few moments speaking about this, that we published one of the first Barnard's paper, and we asked the sites about the average income, and then we looked at the cost of the antibiotics for the treatment of sepsis, ampicillin, gentamicin, which are the first here, and then you can go to potassium amikacin, etc. And then we asked the question, does antibiotic cost influence accessibility? Yes, 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 and yes, and only South Africa said no. So we're doing a much deeper analysis on this about the effect of cost, not just on treatment, but also on diagnostics as well. And this brings me to this slide. And it's one of the things, one of the issues that we have across many low-income countries is diagnostics. Diagnostics are expensive. They're more expensive than antibiotics. So if you have a patient that comes to you with sepsis, chances are you're not going to do the diagnostics. You're just going to empirically treat with antibiotics. But here we go. Cost of diagnostics is very high. Antibiotics is comparatively low. Therefore, diagnostics are not done. Antibiotics are delivered blindly, and we rely on clinical outcome. No idea what type of bacteria or what the drug to treat with it, so got no idea of really what success looks like, and success is only determined by the clinical window. Therefore, we have an increase in morbidity and mortality, and also we don't actually address the global poverty issue either as well, and needless waste of antibiotics, which increases resistance. And at some point, as we've been talking to the ministries in Pakistan, that this cycle has to be broken. So I'm just going to talk about global north versus global south. Many of you would have heard these issues. I personally hate these terms because kind of the global north is usually associated with America and Europe, and global south are low-income countries. And when you look at a compass, the north is always above the south. Really, really unhelpful, and just polarizes the argument even more. But nonetheless, this is sort of the language that is being used in the lead up to United Nations Global Assembly high-level meeting on antimicrobial resistance this year in September in New York. And one of the questions that we asked many of our friends and colleagues in low-income countries is, what is your message to the United Nations? What do you want to see from the UN? And if you have a look at this, antibiotic access is really high. And that may sound very strange in a country that uses a lot of antibiotics, but we actually don't have access to the right antibiotics, to the life-saving drugs. For instance, like we had a discussion yesterday in Peshawar, like injectable phosphomycin, like aztreonam. In Africa, we cannot get amikacin in many places. So what do we have? We have ceftriaxone or ampicillin. It's not good enough because the bacteria are resistant to them. So antibiotic access is really important. We have sustainable funding, really, really important, and diagnostics access as well. And the last one is infrastructure development, where we're working in Pakistan. We actually help build up labs and facilities to try and improve laboratory services so we can improve diagnostics. So this is just some of the kind of backdoor diplomacy which we're doing at the moment. I am actually an advisor to the Nigerian government. I don't look very Nigerian, but nonetheless they've sort of accepted me. And this guy here is Ali Pati, who's the Nigerian Minister of Health. We've also had lots of meetings with the Chinese embassy. And only 2 or 3 weeks ago, we were in China, in Beijing, meeting with the Chinese government. China produces 60% of all the antibiotics used in animals, 49% of the antibiotics across the world. So if we're going to have a United Nations meeting on antimicrobial resistance, China has to be part of those discussions. To not do so is simply rather silly, to put it mildly. So managing drug-resistant infections, is it solvable? Yes, it is solvable, but at the moment we don't seem to have the political will. And trying to, I'm a scientist, but I also do quite a lot of advocacy and also politics. And what we're trying to do is to convey a message to politicians to make sure to keep it really bite-sized, that this is really important and we need to address it in a way. The solutions are known. That's the crazy thing about this. The solutions are known. There is money available in the global health fund, but we're actually not allowing or not helping countries access it. And so there is a solution, but at the moment, that solution is not being grasped by many countries. I'm going to finish up with just some thanks to my team, who are part of all of this data, and including, including, this is about 50 people there or thereabouts, so we're a big unit. And this is some of our international team. I think this is actually Barnard's, as I said, where we work across many countries, including Pakistan. I've just missed the dong for my time up, and I really wanted to do that because it sounded like in English a holiday camp gong, okay, and I didn't want that embarrassment. Anyway, so I've managed to miss that by about a minute, so all I would do and conclude is to thank you for your attention in the languages in the countries from which we work.